Without further ado, I'm going to introduce our first speaker, Tonya Palermo. For anyone in the pain field, you don't have to introduce Tonya. She's really an international leader in the study of pain in children. So I'm not going to spend a lot of time. I'm just going to tell a funny anecdote from this morning. When I do these introductions, I don't ever use anything printed because it's like stale to like read introductions of people. And I got up and I said, well, I'm going to just talk about Tonya and what a great researcher she is, but also how in any setting where I've been in a meeting, she really values the mentees and the junior faculty and is really extremely thinks it's important for us to be mentoring the next generation. So about 45 minutes or so ago, I'm sitting with someone that might be newly joining our group. She can out herself later to you, Tonya, if she cares to. But she goes, I've never met Tonya Palermo, but I had a dream about her. and we said, whoa, what was the dream? And like Tonya was like on a big screen TV, and she was like the one evaluating my presentation on this like big screen. She goes, and we said, well, I'll bet she was constructive and good and helpful. And she said, yeah, she was. So anyway, Tonya, again, a leader in international pain research in children, and again, someone who, like the rest of us, feels very strongly about training the next generation of pain researchers. So Tonya, thank you.
Thank you, Dan. And the funniest thing is I actually had the opportunity at lunch to get introduced to the person in question, who I also heard this story from. So it was terrific. Thank you to the organizers for inviting me. This is actually my first time in Ann Arbor, so nice to be here and appreciate the chance to talk with you all today. All right, this slide just shows my disclosures in terms of grant support and royalties for a few books from Oxford University Press. So I want to just lay the ground in terms of some context around pediatric chronic pain before we get into my talk, and want to start with a little bit of epidemiology. So pain is a very common problem throughout the lifespan, and we know that in adolescence it's also quite common. There's global estimates. This is an estimate from a study of about 44 countries that 44% of adolescents have chronic weekly pain. If we look at pain that's accompanied by moderate to severe disability, the number is 5 to 8% of adolescents. And in childhood, there's lots of types of pain, just as an adult. But the most common locations of bodily pain are in the head, the abdomen, the back, and the limbs. And we know that in childhood, multiple pains and widespread pain is also quite common. The peak rise in the incidence of chronic pain during adolescence is in mid-adolescence at ages 14 to 15 years. And we know that after puberty, girls have a greater incidence of chronic pain than boys for almost all chronic pain conditions, and that continues into adulthood. And I'm going to get back to these 2 points and talk a little bit about pubertal development and pain in a bit. So pain in children matters because it really impacts most areas of daily life for children. This includes things like school attendance, ability to spend time with peers and doing normal social activities, ability to engage in recreational activities and physical activity. It also impacts psychosocial functioning. And for kids, there's a large impact on ability to just sustain normal routines. Pain in childhood is also important because it impacts the parents and families who take care of these children. You know that parents describe burden of caring for a child with chronic pain. They can have their own feelings of depression and anxiety, as well as anger and hostility. Parents report feelings of being blamed for their child's pain or disability and experience isolation and a lack of social support. There's also a real financial burden in terms of direct cost of medical care for treating chronic pain, as well as indirect cost in terms of lost work productivity. Indeed, pediatric chronic pain is costly. Most of the national estimates about the cost of pain have excluded children, and Niels Grunwald from my group had looked at the cost of pain in this study, where he found a database that had other common childhood conditions, including ADHD, obesity, and asthma, and he compared cost for pain-related conditions to these, finding, as you see in the red bar, that pain-related conditions have much greater expenditures compared to other common childhood conditions. And really, the costs are compounded when we think about the potential for these to be incurred across the lifespan. And that's really the exponential cost that will occur if children continue with pain. So similar to adults, we know that there's disparities in the management of pain in childhood. This is a study done at University of Washington looking at emergency department management of pediatric migraine, and finding that children who are from underrepresented racial and ethnic groups and whose parents had a non-English language of care were less likely to get standard of care or evidence-based care treatment of migraine in the emergency room. And this is, if you think about children's voices in medical care, they're pretty silenced in comparison to adults even. So the need to rely on adults for advocacy is much greater. And we know that across childhood, pain is undertreated, but in particular for children of color, we know this is a significant issue. So pain matters in children. Also matters because we now have pretty good data that children do not grow out of pain. There were myths previously that most pain would be resolved and children would not experience it after childhood. But we know from several longitudinal studies, this is an example from Lynn Walker's group in Vanderbilt showing what happens with a cohort with functional abdominal pain in childhood. And so she studied a cohort that had functional abdominal pain and then a well cohort, and they were well characterized in childhood, and then she followed them up in early adulthood at ages 18 to 32. And what they found is that 35% of patients had the same symptoms, so a continuation of their functional abdominal pain in adulthood. But importantly, many had non-abdominal pain as well. So we had a large group with headache, and almost half of these individuals had sites of non-chronic abdominal pain. So increased risk for all forms of chronic pain in adulthood. Also increased risk for anxiety and depression in adulthood. And this has been replicated now, the same pattern of findings in other pain conditions. So we know this is also true for kids who experience musculoskeletal pain in childhood, as well as headache in childhood, that they have incurred a greater risk for continuation of pain in adulthood. So Caitlin Murray, who's a colleague of mine in Seattle, was interested not just in whether pain continues, but what is the impact of having had childhood pain on other aspects of adult life. And so she used the AdHealth data set, which provides waves of data collection from childhood into adulthood, and examined a cohort that had chronic pain in adolescence and a cohort who did not, and looked at some outcomes in terms of education, vocational outcomes, and social outcomes. And what she found is that in terms of educational outcomes, having had adolescent chronic pain, you were less likely to have received a high school diploma or a college degree in young adulthood compared to individuals who did not have chronic pain in adolescence. In terms of vocational outcomes, there was a lower likelihood of having employer-provided insurance benefits, which indicates a less stable job, and an increased likelihood of having public assistance or disability in young adulthood. And so profound impact of adolescent chronic pain on vocational outcomes as well. And then last, in the social domain, those who had adolescent chronic pain were more likely to have early pregnancy and also lower relationship satisfaction than those who did not. So really seeing that growing up with adolescent chronic pain, we talked about the various impairments that causes in daily life, that experience affects adult life in meaningful ways. And even if pain itself doesn't continue, the risks that have been incurred in childhood and the changes in experience are still important to consider in adult life. And I hope this really motivates and sets the stage for why it's important to think about what happens in childhood in terms of both pain prevention as well as pain management in adulthood. So I want to just focus on a couple of topics today that emphasize how pediatric research can impact the study of pain mechanisms and pain treatments across the lifespan. and want to focus on get back to this issue of pubertal development and pain and talk a little bit about sex differences as well as biological changes in sleep during puberty and potential treatment mechanisms. And then secondly, talk about the promise of digital health for chronic pain treatment delivery. So as I showed the epidemiology of chronic pain in childhood, you might have wondered, why does pain increase in a sex-dependent way after puberty? Or for clinicians in the audience, why is my typical patient in pain clinic, pediatric pain clinic, a 15-year-old female? So let's talk a little bit about pubertal development and pain. So this is some early work from Linda Laresh, who was at University of Washington, looking at the relationship between pubertal development and a variety of pain conditions in childhood. And what they found is with increasing pubertal development, this is a self-report scale, the pubertal development scale, that you can see that there's an increasing prevalence of most forms of chronic pain. And this changes in a sex-dependent manner as puberty advances. So you can see girls who are shown in the solid line start to have a greater prevalence of most pain conditions. And it's quite dramatic for some, such as abdominal pain, where the difference between males and females is quite large during early stages of puberty even. So this really kind of started to raise the question of how and why pubertal development is related to increases in pain. Let's see. Going? Okay. So aspects of puberty, such as age at menarche, have also been studied in relationship to adult chronic pain. This is a study from the Tromsø study, which has followed, it's a population-based study. I think I don't remember if it's Norway or Finland, and has followed individuals over multiple data waves. And you can see earlier age at menarche. So for example, early menarche would be defined as 9 to 10 years, that you can see the prevalence of chronic pain in adulthood at several later data waves. This is in adults are age, I think, about 40 to 45 at these data waves. There's a higher prevalence of chronic pain versus those who had later menarche. So it seems to be an association shown here. And this study was interesting because they also looked at where pain occurred in body regions and looked at widespread pain. And you can see the darker the body area is, the higher prevalence of chronic pain there. And this is divided by early menarche, typical menarche, and late menarche. And you can see that earlier menarche, which is shown all the way on the left, is associated with more regions of bodily pain. And this is a more recent study from our lab that was undertaken by Ray Lee, who is an amazing postdoctoral fellow in my lab. She used the ABCD data set, which it's a population-based study of children in the US. And what she was really interested in is how does pubertal development in terms of both self-report puberty as well as sex hormones relate to incidence of new chronic pain onset. And so she characterized a sample that did not have chronic pain at baseline, so they're pain-free. And at the first data wave, they're about 11 years, and second data wave, they're about 12 years. And she looked at self-reported puberty in several ways. One, just the overall pubertal maturation. And then she also looked at the change. So how much did they just change in their pubertal development from time 1 to time 2? And then what she called pubertal asynchrony, which was, are there certain aspects of development that are occurring faster or slower than others between those two waves? And then she looked at sex hormones. This data set has salivary levels of DHEA, testosterone, and estradiol. And her main outcome was really the new onset of pain in this population at the year 2. And then she looked at some pain characteristics. So what Ray found is that across both sexes, there was higher pubertal development, so more advanced pubertal development was associated with greater risk of pain onset. So this replicates what's been shown in other samples. And Interestingly, she did find some sex-specific effects for boys only, where not only pubertal development, but also pubertal progression from time 1 to time 2, and sex hormone levels were related to pain incidence and risk. In this case, higher testosterone and DHEA were protective. They were associated with lower risk of chronic pain development. And this is interesting. There's not been a lot of work done on sex hormones in adolescents to understand this pattern of findings necessarily, but she's interested in following this up with some other studies in the future. So biological changes occurring during puberty are just one aspect of pubertal development. We know there's a ton of psychosocial changes happening both with puberty as well as during adolescence. These are things like changes in autonomy and independence in adolescence, changes in an increase, unfortunately, in anxiety and depression in adolescence, as well as increase in risk-taking and reward processing. In terms of social relationships, there's dramatic changes in peer relationships, as well as increases in family conflict. And lots of support for how each of these individual factors can impact pain, both in terms of experimental pain as well as clinical pain, but hasn't been a lot of studies that have looked at both biological as well as psychosocial factors together in terms of how does pubertal development affect the onset of pain. So lots of work to do. So I wanted to just start with one factor that is really important during puberty that our lab does a lot of work on, which is sleep. And for those of you who have teenagers, you may know that sleep changes a lot. And I remember when my oldest child was maybe 12, I realized, wow, I'm gonna be the first person going to bed, like from now on. And so there's dramatic change. And so why does that happen? There's actually biological changes during puberty that are associated with advancing pubertal development that account for this. So this first figure shows Tanner stage, so more advanced puberty with later Tanner stage and melatonin onset time. And you can see there's about a 2-hour shift in when the body produces melatonin with later pubertal development. And so what does this mean? This means like a 2-hour shift in your circadian phase over puberty. And this accounts for later bedtimes for adolescents that are biological. They don't feel sleepy earlier because of this shift in their circadian pattern. There's also what's called a slowed rise of sleep pressure. So across childhood, very young children can fall asleep extremely quickly, and this is because their sleep pressure is quite high. But over time, as you age, and especially by mid-puberty, you have a very slowed rise in sleep pressure, meaning you don't feel like you're gonna fall asleep that fast. You don't have that pressure to sleep. And the result of this is really shortened total sleep time that happens extremely fast. So this shows just from ages 10.5 years to 12.5 years. As beginning of puberty progresses, you can see that sleep times start shortening, and this just continues. So after 12, they continue to go down, and the average 16 to 18-year-old is sleeping less than 7 hours. So tremendous change in total sleep time, and some sex-specific differences where actually boys start sleeping less than girls. Other important aspect of sleep during puberty is the change in or development of insomnia symptoms. We know that both adolescent girls and women have a 50% greater risk of developing insomnia compared with boys and men, and that this actually starts during pubertal maturation, where there's an association between pubertal development and insomnia. And you can see in these figures, girls are shown in the red line and boys in the blue line. As pubertal stage advances, we see higher prevalence of insomnia, and we see a sex interaction here where girls have a higher prevalence of insomnia with later pubertal development. And similarly, if you look at just the severity of insomnia symptoms, they also increase in a sex-specific manner with advancing pubertal development. So by the end of puberty, girls have a much greater prevalence of insomnia as well as more severe symptoms. So why what are the possible mechanisms that account for this? We know there's, as I mentioned, there's an increase in anxiety and depressive symptoms during adolescence. Post-puberty, this occurs in girls as well, which may account for some of the difference. There's also differences in stress reactivity that also might account for these changes that increase likelihood of insomnia. So this is a figure that I really like that Mary Carskaden has published on. She's a sleep researcher who's done a lot of work on the biological changes in sleep during adolescence. And what she's really described is that adolescent development and sleep is the perfect storm. So we've got these biological changes that I talked about regarding your circadian phase delay, as well as this slowed rise of sleep pressure. But on top of that, you have all this psychosocial pressure. So teens start having more autonomy at bedtime. They also have increased academic pressure to stay up at night and do things related to schoolwork. They also have screen time and social demands that keep them up late. And at the same time, we have a societal pressure for an early rise. So teens get up the earliest as they progress in adolescence to go to school. They also have sports practices early in the morning. So we have this late to bed, early to rise phenomenon that has really resulted in short sleep for adolescents. So interesting to me as a psychologist thinking about both the biological and behavioral mechanisms that are happening during this time period and how this might affect the development of chronic pain. So we know that across the lifespan, there's an association between having pain and reporting sleep problems. At least 50% of individuals with chronic pain report sleep problems. We've studied this in adolescence and found that insomnia is the most common sleep problem. And this is also interestingly predictive. Just having insomnia in adolescence is predictive of adult chronic pain, even if you did not have pain in adolescence. So we know that this sequence of having sleep problems leading to subsequent pain is true both in clinical populations and has also been demonstrated in experimental studies. So I've been really interested in thinking about sleep impairments as a way to really understand how people do or do not benefit from treatments. So if we think about what happens when people have sleep impairments, it affects your daytime functioning in multiple ways. You have sleepiness that causes inattention and memory problems. You have more difficulties regulating your emotions when you haven't slept well. And this can result in a variety of performance problems, everything from your physical performance to your cognitive performance on task. And it also affects motivation. And all of you know when you have not slept well, it's very hard to be motivated to do things during the day. It's hard to especially get motivated to try new things. And so if we think about what it takes to teach people about self-management of pain in the context of having difficulties with attention, with memory, with motivation, and as a psychologist, I want to teach them these self-management strategies. It's a really hard context for learning. Learning requires having good sleep to consolidate information and to retrieve information, to use it at the time that you need it. And so sleep is really what I would say is a foundational requirement for learning self-management. And so what can we do when we have people with sleep impairment who we are trying to really teach these new skills? And so we wanted to explore this in some of our treatment studies, trying to understand, does sleep moderate the effectiveness of our treatment? We think it did from observations anecdotally, but wanted to test this. So we measured sleep in a couple different ways, looking at subjective sleep quality, self-report of insomnia symptoms, and then also using actigraphy to look at sleep duration and wake time after sleep onset. And all of these youth underwent a CBT, cognitive behavioral treatment program for pain. So they're learning pain management skills. And we looked at how sleep at baseline might have modified the effectiveness of treatment on different pain outcomes. And we found pretty strong effects, especially for sleep quality and insomnia. So if you started off with high levels of insomnia, poor sleep quality, you had a much reduced response to treatment. And that's even when we control for the level of engagement. So even if you did just as much of the treatment, you did not benefit as much from it. And so we saw that in lots of different pain outcomes, including less improvement in disability and in overall health. So again, just to remind you of the model that I'm thinking about here, we know sleepiness causes problems with distractibility, inattention, and motivation. These are concepts that fall under what's called executive functioning. And I've already talked about the path between sleep deficiency and treatment outcomes, but now we wanted to look at what are some possible behavioral mechanisms. So we really wanted to focus on whether executive functioning as well as self-management, this is your confidence in implementing skills for yourself to manage health and your ability to carry those out, and looked at specifically treatment outcomes in terms of pain-related disability. So we tested this model. This is like really busy, so apologies. But the important thing is just to see the pathways. And so the solid lines are paths that are significant. And you can see that as we hypothesized, insomnia reduces executive functioning, which reduces self-management and leads to lower disability. So we found some confirmation for that pathway. Why is this important? Again, we're really trying to show why does sleep problems affect ability to benefit from psychological treatments. And although we're focusing on psychological treatments, I want you to think about whatever treatments you might deliver to your patients, because similarly, many of our treatments require learning new things, being able to remember to do them, and having the motivation to carry them out. So what are we doing with this information? Really, this told us that we need to treat insomnia first and make a difference in sleep before we try delivering other forms of pain intervention. My colleague Emily Law is working on this in a study of migraine, where she is sequencing treatment of insomnia and treatment of the pain-related part of that, and has a couple of groups so she can see which order is optimal for this population. And it'll be interesting to see what she finds, but our hypothesis is that the adolescents who get insomnia treatment first are going to benefit the most. All right, so now I'm going to completely take a different direction and go from treatment mechanisms to talking about how we deliver treatment. We do a lot of delivery of treatment by digital health, and the interest in that in my early career was to give patients better access, to make treatments accessible, and hopefully more equitable to all people with chronic pain. So that was the early promise of digital health. And for those who work with children, this was really emphasized in childhood because kids grew up with technology. They were considered to have an affinity for technology. And I think a lot of early focus was actually on children for that reason. They were called digital natives. And I should think this is funny, their parents were called digital immigrants. We were brought into technology later. So my first experience with technology was actually in pain assessment, where my goal was to enhance just measurement of pain. And why is this important? I thought that real-time measurement of pain could lead us to then deliver interventions in real time that might benefit people. I don't know who knows what a PDA is. Anyone my age or older remember what a PDA is? Okay. So this was a personal digital assistant. It was one early version. We had Palm Pilots. This one we used was called an HP Hornata. And super exciting because it gave a way to do real-time measurement of symptoms. And a funny story, this was, I think I was just finishing a K award. I had no money, wanted to do this study. I actually wrote to Hewlett-Packard and described the study I wanted to do, and they sent me free devices. Would that happen today? So it was, but we really wanted to show that we were able to capture symptoms in youth, and so did a small trial where we just compared paper-based diaries to electronic diaries, looked at whether this improved compliance with measurement, and we had some ways of looking at accuracy too, and found overwhelmingly youth were much more engaged with electronic diaries. We had good compliance and accuracy data, and this was in a mixed population, kids with sickle cell disease, arthritis, and headache. So got interested in what we could do with technology. And again, my original motivation was to reduce barriers to receiving evidence-based pain treatment, in this case, psychological treatment for pain. In pediatrics, we have fewer pain clinics than there are devoted to adults with chronic pain. In most states, there's one clinic that serves a huge geographic area, and that's true where I live in Washington. And we know that there's long waiting list for kids to get into to a pain clinic to see providers. Even when they get in, there are continued barriers to access. And so the mean number of visits of a child in pain clinic is 1 to 2 visits. They're really not able to continue to receive regular care. So even when we can get people into clinic, it's very hard to deliver psychological treatment on a regular basis to the population. And that's mostly because of the distance. When I first moved to Oregon in 2004, I was working clinically, and the first patient I had was from Coos Bay. I had to put up a map in my office because I had no idea where anything was, but it was like, wow, they're driving 5 hours one way to come to a visit. And so they're taking off the entire day, traveling very far, and how am I supposed to help families like that? And so I got really interested in thinking, what can we do to take technology into the home to deliver evidence-based pain care? So I had started some work on a program that I called Web-Based Management of Adolescent Pain. Early on, we were really interested just in developing the intervention. We did a lot of user design sessions with teens with chronic pain to understand what they wanted from an intervention, did some usability testing to see if kids would do this and how could we engage them, and then did a pilot randomized controlled trial. We worked on understanding some components of our treatment that worked, and then did a large multi-center RCT. And since that time, have continued to develop other versions of the intervention. We converted it to a mobile app for easier dissemination, and have done extensions to some new populations as well. We're also trying to focus more on implementation and dissemination research, and have more recently started working on some cultural adaptation. So one of the big problems in research on this form of intervention, so using digital health, is that at the end of the study, the products are not accessible to end users, so people who need them, who have pain. This is a systematic review done in looking at pediatric pain tools, finding that only 28% were available to end users after studies were over. Lots of barriers, as you might imagine, particularly around funding, being able to maintain programs over time, especially with changes in technology, frequent changes in operating systems. So really the conclusion of this review was that we need to incorporate implementation work earlier so that at the end of studies, we have a plan for successful sustainability of the intervention. So we did that with our WebMap intervention through some funding to convert our web-based program into a mobile app. We did that because particularly with teens, it's quite hard to disseminate a website with minors in particular, and it's much easier to actually disseminate something in the App Store to minors under an educational content category. So that's something that we kind of learned along the way that would make this much more accessible, and conducted an implementation effectiveness trial. So we retained most of our core treatment components. This is fairly standard cognitive behavioral treatment for chronic pain in children. It incorporates a variety of focused topic areas, and then we tailor a few modules for low mood and insomnia, where youth who have those symptoms can receive some additional care. This slide just shows some of the components of the app. We present skills in lessons. We have a library that you can go back to and look at some focused topics. We do rewards for making progress in the app. There's a daily check-in feature that gives youth a chance to look at progress on pain, activity, sleep, and mood, and then we let them track skills as they progress through the program and learn new skills. As I mentioned, we do a little bit of tailoring when youth first set up the app. They do a profile, and this gives us a chance to screen for insomnia and low mood. We just have 2-item screening for insomnia that's shown here, and if they screen positive, they have an additional lesson provided to them that's focused on some insomnia interventions. And we do the same thing for low mood. So what we found in our effectiveness implementation trial is that in the real world, where we are not monitoring app use, that it's much lower than in a randomized controlled trial that's tightly controlled. And so real world engagement was about half of what it is when we're encouraging youth to use the product. So most kids did about 3 of 6 lessons, which isn't terrible. They had some exposure to the app, but we did find that engagement was really related to outcome, as you might imagine. So kids who did more had more improvement in pain-related disability. Our implementation results were really positive. We implemented this in pain clinics and in abdominal and headache clinics in some children's hospitals around the US, and found that providers used the app with their patients. At the end of the study, they maintained use, so they continued to refer patients to the app, and new patients continued to use the product after the study was over, which was our main goal, was to encourage a pattern where providers saw this as a resource and continued to use it with their patients. So we publicly released the app in September of 2019, and we've been maintaining it since then for free access on both Android and iPhone. We have tried to disseminate flyers and have done a little bit of promotion, especially during the pandemic, to try to remind people that this was free and available for access. So our next steps are trying to understand how best to increase engagement. As mentioned, it's a problem with all mobile applications, but I think in particular, we've learned some lessons over the years that from patients who have told us what's working in the app and what isn't. And I'll show you some things in a moment. And then we're really wanting to move into some cultural adaptation. So this is a new partnership with Tara Brinkman at St. Jude with some funding for a trial called Culturally Adapted Mobile Treatment of Chronic Pain in Adolescent Survivors of Pediatric Bone Sarcoma. And this is kind of a neat study that Tara wanted to do, where she wanted to combine our WebMap Mobile CBT program with an intervention that she has studied, which is transcranial direct current stimulation, which is also delivered mobily through a kit that's sent home that kids are shown how to use. The population is 10 to 17-year-old Hispanic or non-Hispanic Black survivors of childhood cancer who are at least 1 year post-treatment. And there's a lot of innovation in this study. We've never combined our cognitive behavioral intervention with another treatment. So this combination of treatments is interesting to me, especially because if we think about sleep as a mechanism, these are actually 2 treatments that might help with sleep. They also might help with pain in different ways. So it'll be interesting to see that. We also are focusing on disparities. And this is the first intervention for chronic pain in adolescent cancer survivors, surprisingly. So give us a chance to see for this population that really has not been prioritized in some of the work to see how they do with these interventions. Right now, we're conducting focus groups that are guided by a model called the ecological validity model that helps understand what aspects of a behavioral intervention should be adapted for different cultures. So we're undergoing those focus groups now. And then what I'm really going to focus on with the tailoring, I showed you the profile. So we can set up a profile for each child that does lots of different types of personalization. So we're going to try to learn what do kids from different cultural groups want in terms of personalization, and see if we can incorporate that into the profile to help personalize both the content as well as delivery. And we're also really trying to make use of some lessons learned from a recent trial we completed with digital cognitive behavioral therapy in pediatric sickle cell disease. And I want to tell you just a little bit about this trial that, that I did with two colleagues, with Carlton Dampier from Emory and Jen Stenson from Hospital for Sick Kids. And this really was meant to gather evidence for cognitive behavioral therapy in sickle cell disease pain management. Although it's been used clinically for many years, there's very few trials that have tested cognitive behavioral therapy in this population. And we know, obviously, that CBT is helpful in other pain populations, so hypothesized that it would be helpful in this population as well. We compared treatment to an education control condition, which was all delivered digitally. And main outcomes were pain severity and activity limitations, as well as coping strategies. So this was a multi-center randomized controlled trial with 7 sites, and we enrolled youth who were ages 12 to 18 years with sickle cell disease, and randomized them to either get an intervention called I Can Cope with sickle cell disease, or an education control website. And had an 8-week treatment period, studied our outcomes at post-treatment as well as at 6-month follow-up. We had a great retention in this trial. We had 92% that completed post-treatment, 88% that completed 6-month follow-up. So really, I'll talk in a moment about what I think helped with that great retention rate. This slide shows our products. We settled on delivering intervention with both a mobile app and a website. And that was because the mobile app was meant to be done daily with short exercises that could be done in the moment, and things like joining a community and posting a question to other kids. They could monitor a few things and set goals. And then the website was meant to be more in-depth learning about pain. We had a profile where kids could personalize things in this app as well. And this just shows our main outcomes. You can see that for daily pain and number of days with pain, we had significant reductions, as well as improvements in coping attempts. And the slide just shows the same thing, reductions in pain days as well as pain intensity for kids who received the I Can Cope intervention. We also did qualitative interviews, and we learned quickly that kids actually only use the app. We also saw it from our usage data. They used the website very infrequently, but really enjoyed the daily opportunities the app gave them, and really found most of the content on the app helpful. Interestingly, they also enjoyed sharing within the family. This was a surprise in terms of they generalized some of the skills and taught younger siblings these skills, which was really neat to see. Just a quick note about making clinical trials more inclusive, and a shout out to Mary Janovic for this paper that was published in Journal of Pain last year that gives really practical strategies for making trials inclusive. But I think having remote interventions that require no in-person procedures, like we did in our trial, gave an opportunity for individuals to participate who might not have otherwise. We also worked really hard to build engagement with stakeholders. So this was one of the questions I had hoped digital interventions would accomplish, which was to improve equity and access to chronic pain treatments. Sadly, I'm going to go a little quickly because I'm running out of time. But although we have a lot of digital interventions now, this question still cannot be answered because most trials have not reported on race and ethnicity of samples. So it's actually not possible to understand whether treatments have been equitably delivered with digital health. There is a nice review in Press in Pain across all pain clinical trials, not just digital health, that shows that only 40% of individual trials reported race of participants. So this is an area that we really need to improve on. And just 2 slides with my editor's hat on. So reporting is important. And this is a editorial that I banded together with 8 other pain journals to promote inclusion in pain science, and was able to put together some guiding principles for authors and reviewers around inclusion. For Journal of Pain, what that looks like is shown here. We have guidelines on use of inclusive language, on accurate interpretation of race, ethnicity, sex, and gender, on inclusion and representativeness of study samples, and comprehensively reporting sample characteristics. So we are requiring all authors for all studies to report comprehensive demographics, which will help in answering some questions about equity that we need to answer. So quick summary, we know that chronic pain is common in childhood and that unfortunately can have a significantly lasting impact into adulthood. So it's important to consider prevention and management in childhood. As I showed you, advanced pubertal maturity is a robust risk factor for the onset of adolescent pain across both sexes, as well as some sex-specific effects that I showed you in boys. There are biological changes in sleep that occur during puberty and differences in insomnia that also might account for some of the connections we see between sleep and pain later in life. And as I showed you, digital health interventions can be implemented in many populations. We don't know yet if we can address barriers to access or equity of pain care. A few future directions. I think we can definitely consider sex-specific prevention strategies for pain in the future. This might be at menarche for girls or delivering sleep-focused strategies during adolescence. As I showed you, it's important to use research designs and procedures to increase inclusiveness of study samples in our pain research. All right, I'm gonna skip those. Quick note about studying prevention across the pipeline. I just wanna point out that we often talk about time as being the course of pain, so time might be acute to chronic, but I really want to reframe that time is also lifespan. And so we really think about prevention in childhood as affecting adult pain. It will help us reframe some of our approaches. So for example, universal prevention in childhood could look like school-based programs that teach children some skills for managing everyday discomfort, to give them skills to effectively, hopefully, cope with symptoms and reduce the incidence of adult pain. But I think the more we can connect this window of opportunity in childhood for prevention with adult outcomes, that will have probably better engagement. But there's been surprisingly few universal prevention attempts in pain management. So an area that's really a gap. Most work has focused on either secondary and primarily tertiary prevention. Quick thank you to my lab who contributed to a lot of the work that I showed today, and then wanted to just show my contact information. And I don't know if I'm taking questions now, but...
You are.
Okay, great.
We have time for a couple questions for Tonya. Andrew?
That was such a great talk. Thank you so much.
Sure.
My question is, it really appears to be a robust finding of early onset puberty, so the first risk for chronic pain, at least in adulthood.
Right.
Are we able to see epidemiologically, as the onset of puberty has gotten earlier and earlier in kids, can we see a commensurate increase in the prevalence of chronic pain in adolescents? Is that showing up in the data?
That's a good question. You know, unfortunately, most epi studies use age as a proxy for development. They don't actually measure pubertal status. So you can answer the question about age, and we know that pain is increasing in childhood in epidemiological surveys, and I can't say that there's clear evidence of the shift being lower for the incidence, but my guess is that would be the likely pattern. But I think we really need to encourage large studies to use scales of pubertal development so we can actually ask that question. Yeah. Thanks.
Sam?
Fantastic talk. One question I had, you've been so innovative in so many ways, Tonya, and I wondered, in the app that you released, how much does it cost you per year just to keep it current with like all the new, iOS is new, or there's a new, what's that expense ongoing for that? It's so wonderful that you have that released. I'm just curious, what's your operating cost?
It's a great question, and I will be honest that some years it's much more because of how many updates there are. This was a bad year, so I actually spent about $30,000 this year. Other years it's been less. I have a gift fund that people have donated to from community sponsors that I use for that purpose, but it is a real cost.
Right, that's such a barrier.
Yeah.
Right, it's so awesome you're doing that, so hats off to you.
One more question. We have time for one more question. Any other questions?
Yeah.
I also think about, so I know you mentioned as far as like the development of chronic pain across the lifespan. I was also thinking about just from like a psychological perspective, any research on like trauma, PTSD, some of those factors early in life, how that, you talk about the discomfort, coping with the discomfort, if
Yeah.
there's anything you could add to that.
Yeah. Oh, it's a great question about the relationship between, not just trauma, but actually early life stress and chronic pain. And there's lots of ongoing efforts. We know that even prenatal early life stress is related to development of, a variety of health conditions. There is not as conclusive of work in childhood pain about that question, but much more about the relationship between trauma and pain. And there's been studies of prevalence of PTSD showing associations with new onset pain as well in childhood. So I think it's an important area. I would love to encourage people who have birth cohort studies to measure pain better in childhood so we can actually ask those questions better about early life stress.
Great. Thanks so much,
Okay,
Tonya.
thank you.